Hello everyone, I'm Dr. Shruti Hedgire, second year DNB resident BRC Hospital, Mumbai. My topic for discussion is evaluation of the pituitary lesions. The pituitary gland is an endocrine gland that plays a vital role in process of growth, homeostasis, and reproduction. The tumors of pituitary gland are second most frequently reported CNS tumors after the meningioma. They can present symptomatically either due to hormonal imbalance or mass effect or diagnosed incidentally. The various pathologies arising from pituitary are adenomas, tuberculosis, sarcoidosis, abscesses, and embryonal tumor arises from anterior pituitary. Rathke's cleft cyst and craniopharyngioma arises from Rathke's cleft. Pituitocytoma arises from posterior pituitary. MRI is the commonest imaging modality used for the evaluation of the pituitary lesions. A study was conducted for the evaluation of the incidence of pituitary lesions in our hospital population and describing the features of them. A quick review of anatomy. The pituitary is situated in sella turcica, located between the greater and lesser wings of spinat, anteriorly bounded by the tuberum cellae and posteriorly by the dorsum cellae. On the either side lies the cavernous sinuses. The dural layer overlying the sella is called as the diaphragma sella that separates the pituitary fossa from the intracranial, subdural, and subarachnoid spaces. Embryologically, the pituitary is differentiated into anterior adenohypophysis that arises from Rathke's pouch and posterior neurohypophysis that arises from neuroectoderm. The posterior pituitary is connected to hypothalamus by infundibulum or stalk. The pars intermedia is a small region between the adeno and neurohypophysis at the attachment of the infundibulum. Most of lesion arises from the anterior pituitary. The lesion may extend into the suprasellar region, compressing the hypothalamus and optic chiasm, and may extend laterally into the cavernous sinuses, encasing the cavernous segment of ICA. 30 patients, symptomatic or asymptomatic, were referred to the radiology department for the evaluation of the suspected pituitary lesions. All patients underwent contrast examination. Gadolinium was used as a contrast agent. Detailed pituitary protocol was performed. MRI protocol used is 3 mm size thin slices were taken. Small FOV is used. Planning was done on T2 sagittal section. T1 and T2 sagittal and coronal images were obtained. Post-contrast T1 sagittal and coronal images were obtained. Dynamic sequence was used for suspected cases of microadenoma. Consecutive sets of 3 in coronal plane taken at every 10 seconds after the contrast injection for 2 minutes. Before moving to cases, let's understand the MRI anatomy of pituitary. Anterior lobe is isointense to gray matter on T1 and T2. Posterior lobe is hyperintense on T1, gives characteristic white spot due to stored granules of vasopressin. After the contrast injection, the pituitary shows homogeneous enhancement. The pattern of enhancement is centrifugal. First case is 18-year-old girl presented with menstrual irregularities. Investigation revealed raised prolactin levels. On imaging, isointense lesion is seen in right half of pituitary. It is difficult to delineate the lesion on plain T1 sequence. Dynamic contrast scan was used. We can see delayed enhancing nodule in the right half of pituitary compared to the normally enhancing pituitary gland surrounding the lesion. The normal pituitary shows enhancement at 60 to 80 seconds while the microadenoma shows delayed enhancement at 90 to 120 seconds. The diagnosis of pituitary microadenoma was made. The next case is 55-year-old male presented with symptoms of headache and visual disturbances. On imaging, we can see heterogeneous T1 and T2 isointense lesion in the pituitary fossa that extend into the suprasellar region, compressing the optic chiasm and extending into the left cavernous sinus, encasing or abutting the cavernous segment of ICA. The lesion revealed mild to moderate homogeneous enhancement on post-contrast images. The diagnosis of pituitary macroadenoma was made. NOS classification was used to grade the paracellular extension of pituitary macroadenoma. Tangential parallel lines are drawn along the medial and lateral margins of cavernous segment of ICA and supraclavicular segment of ICA. These are referred as medial and the lateral line. The middle line is drawn in between the two lines. Grade 0 is the lesion not crossing the medial line. Grade 1 is the lesion crossing the medial line but not crossing the midline. Grade 2 is the lesion crossing the midline but not crossing the lateral line. Grade 3 is the lesion crossing the lateral line. Grade 3A refers to superior cavernous sinus compartment and grade 4 refers to lesion in inferior cavernous sinus compartment. Grade 4 is complete encasement of ICA. In our study, out of 7 microadenomas, 4 cases were of grade 3. Next case is, out of 7 diagnosed cases of microadenoma, 6 underwent the transfemoral resection of the lesion. On follow-up imaging, 2 of them revealed the recurrence of lesion. T1 isointense lesion is seen in left suprasellar region, which shows homogeneous enhancement after the contrast administration. The diagnosis of recurrence disease was made. Next case is 24-year-old male presented with headache, nausea, vomiting, visual disturbances, and dizziness. Plain CT brain was done, revealed hyperdense areas in pituitary fossa. MRI was done subsequently. Hyperintense signals from pituitary fossa are seen on T1 and T2. We can appreciate the fluid level on T2 sequence as well. On gradient imaging, we can see the areas of blooming surrounding the pituitary. On contrast, on post-contrast image, we can see the non-enhancing lesion surrounded by the normally enhancing pituitary parenchyma. The diagnosis of pituitary apoplexy was made. The T1 and T2 signal intensities of pituitary apoplexy depends on the age of hemorrhage. Next case is 44-year-old male presented with symptoms of giddiness. Plain CT brain was done, which revealed round over hypodense lesion within the sella, extending into the suprasellar region. It is followed on MRI. We can see mildly hyperintense lesion on T1 extending into the suprasellar region. And on T2, it shows the isointense lesion with hypointense nodule within. On post-contrast image, we can see the lesion the lesion is not enhancing, but the normal surrounding pituitary gland is enhancing, which defines the Claus sign. The diagnosis of Rathke's-Cleft cyst was made. 30 patients were evaluated for the suspected pituitary lesions, out of which 16 were found positive for pituitary lesions. Total incidence of pituitary lesion in our hospital population is 53.3%. The 8 cases were suggestive of microadenoma, accounting 50% of the lesion. 7 were suggestive of microadenoma, accounting 43.75%. and 1 was suggestive of Rathke's-Cleft cyst, accounting 6.25%. Out of 7 microadenomas, 2 revealed the features of apoplexy. The pituitary lesions are more common in female, accounting 62% of the lesions, and more common in age group of 20 to 40 years, accounting for 43.7%. In our study, majority of them, that is 68% of them, were symptomatic. The most common pituitary neoplasm are the adenomas originating from the adenohypophysis. They comprises up to 80% of cellular tumor and 10 to 15% of intracranial tumor. They are classified on the basis of size into the microadenoma less than 10 mm and microadenoma more than 10 mm. The microadenoma of size more than 40 mm is referred as giant microadenoma. Clinically, microadenomas can be symptomatic or asymptomatic. In our study, out of 8, 5 cases were symptomatic and 3 were incidentally detected. All of the microadenomas are associated with increased levels of prolactin. Functional microadenomas are symptomatic due to the endocrine dysfunction. Most common functional microadenoma is prolactinoma. Dynamic contrast sequence was useful in since microadenoma shows delayed enhancement compared to the normal surrounding pituitary. Out of 7 microadenomas, 6 were symptomatic, presented with pressure symptoms such as visual disturbances and headache. 2 of the symptomatic microadenomas presented with symptoms of pituitary apoplexy in the form of hypotension and syncope. Only 1 case of microadenoma was diagnosed incidentally. Out of 7 cases, 6 underwent the transfemoral resection, out of which 2 revealed post-op residual tumor or recurrence. Pituitary apoplexy is caused by hemorrhage or infection in the pituitary gland. Clinically presents with features of hypotension, syncope, and vision changes. Rathke's-Cleft cyst arises from the remnants of fetal Rathke's pouch, positioned between the anterior lobe and the pars intermedia. In our study, 1 case of Rathke's-Cleft cyst was incidentally found, incidence being 6.25%. In our study, it was asymptomatic and incidentally detected, but in literature, the symptomatic cases were also reported. Calcification is rare in case of Rathke's-Cleft cyst. The signal intensity of the cyst varies depending on the cyst contents. On T1, 50% are hypointense and 50% are hyperintense. On T2, majority of them are hyperintense, 25 to 30% are iso to hypointense. Intracystic nodule is seen in about 40 to 75% of cases. Craniopharyngioma was not detected in our hospital population, probably due to its rare incidence. But to complete the discussion, we are adding the imaging characteristics from the reference article as follows. It is benign tumor, arises from the squamous epithelial remnants of Rathke's pouch along the craniopharyngeal duct and shows bimodal age distribution. 2 histological subtypes are known, adamantinomatous and squamous papillary type. The adamantinomatous type is more common one and noted in children. It is lobulated, infiltrative, predominantly cystic lesion located in suprasellar region and shows calcification. The squamous type is less common one noted in the adults. It is spherical, predominantly solid, located in intra and suprasellar region and might show calcifications. The other lesions like pituitary mets, pituitocytoma, inflammatory and infectious lesions are rare in occurrence and not found in our hospital population. So the conclusion of my study is pituitary lesions are more common in females and in age group of 20 to 40 years. In our study, majority of them were adenomas and 68% were symptomatic. Pituitary lesions are best evaluated on MRI. MRI is the better modality in characterizing the lesion extent, invasion of the surrounding structures, and characteristic pattern of enhancement. Dynamic sequences are typically useful in diagnosing the microadenomas. Hence, the MRI is the modality of choice for diagnosis of pituitary lesions with high accuracy. These are my references. Thank you for your patient listening.